Well, so while everybody's joining, I just want to say thank you everyone for coming, and I'm just gonna keep admitting people as they come in here. And I want to especially thank our sponsors who are on this side, but I can't. I can't really, let's see if I can get it in for a second. So anyway, we wouldn't be able to have these meetings without our sponsors, Beijing, Bristol Myers Squibb, Sanofi, and GSK. So thank you for your support so we can have these meetings. And
thank you for having these meetings.
yeah, well, thank you. And actually, Dr. Cole, I'd like you to introduce yourself with your big long title because I won't remember it right.
Let's see where name is Craig Dad. And so I'm assistant professor at the Michigan State University Human College of Medicine at Karmanos Cancer Institute at McLaren Greater Lansing.
That's a lot to say.
The more MSU.
So let's start out with just maybe talk a little bit about what you're doing, because you were telling us it was all the things that you're doing here at MSU, and
Yeah.
with that, and then we'll take questions, once we're into that part.
Well, I think though one thing that I really like to thank everyone for is research support, and Sid was kind enough to donate money to our lab and now clinical research and newly diagnosed and smoldering myeloma. And so what was interesting and what I love about being here at MSU is the close collaboration we have with our laboratory group. And it was funny because I was driving between my MSU office and the clinic, and I had heard Dr. Bernard, who's a researcher at MSU, talk about how she was doing research in fat cells and melanoma. And so I'm just driving down Cedar Street, and I heard her say that, and I pulled into like this totally sketchy liquor store and stopped and actually talked to her over during her meeting, saying that, if you're working on that with melanoma, we can really work on that with multiple myeloma, because plasma cells, when you look and do a bone marrow biopsy with myeloma, you see that there are lots and lots of fat cells, and a lot of those and fat globules inside the bone marrow. And the idea for a long time is that a lot of those fat cells were in there just kind of innocent bystanders. But one thing that was probably in the last maybe 5 to 10 years we noticed is that differences in outcomes of patients that are obese with early cell disorder. And and there's been some research looking at that inside the bone marrow of patients that have obesity, the cytokine milieu, or the different hormones and the different growth factors are different in patients with obesity than patients without obesity, which may add to the higher differences in outcomes that are obese. So our hypothesis was that those fat cells aren't innocent bystanders, but they actually participate in myelomagenesis, making myeloma grow, proliferate, and again had differences in outcomes. And so and Dr. Bernard has a very unique model where she can grow adipose cells or fat cells, and put them in close proximity with myeloma cells. We found out that that there are definite signals between adipose tissue cells and myeloma cells that actually promote myeloma growth. And which was, I think, incredibly interesting, is that we usually associate the bone marrow microenvironment with bone marrow stromal cells. And so my research years ago was looking at bone marrow stromal cells, sort of the lattice work that's inside the bone marrow, and that the bone marrow stromal cells, again, are far from innocent bystanders. They are definitely related to myeloma growth, proliferation, and myeloma cell survival. And it was only thought that it was just a two-cell show, the bone marrow stromal cells and the myeloma cells. But now we know that there's a third cell that's involved in myelomogenesis, which are those adipose tissue cells, which also actively signal to myeloma cell to proliferate and grow. And actually, well, I can't tell you that part because we have to publish the paper. But there's something I wish I could tell you, but I will tell you as soon as we publish it. But there's and if it wasn't for, Sid donating money to us, we wouldn't know that. And now the really interesting thing is that we've actually talked to a pharmaceutical company about a way to interrupt that signal between adipose tissue cells and myeloma cells, which could, be an effective, future therapy to break that signal. Because the one thing about bone marrow stromal cells is that bone marrow stromal cells are, they are ubiquitous again through the bone marrow, and all the cells in the bone marrow, their white blood cells, the red blood cells, the platelet cells, also require the bone marrow stromal cells in order to signal. But the adipose tissue cells may be something very unique to myeloma, that if we interrupt that signal, it may be something very specific to myeloma that wouldn't interrupt, other, wouldn't lower the platelet count or the white blood cell count by interrupting that connection. And so kind of the next phase of the research that we're doing here is to get patient samples, test that Thera, and to also have a drug that could interrupt that signaling. So that's part of what we're doing here.
That's a lot.
It's a breakthrough.
I really, I think that's why Jonathan, our postdoc, won the Young Investigator Award through the International Myeloma Society, is because I think there's a lot of potential in that research.
It's really neat.
It's great.
So that, and still, seeing patients and working in clinical trials and everything else.
Well, it's interesting to hear about these new therapies. Right now, so when's your paper coming out?
That's a good question. Because it's still in the writing phase, so probably this summer, or maybe this fall, depending. I think there are a couple more things that we're going to tidy up, but this year we're not submitting abstracts because we're working on the paper instead.
Okay, very good.
So by September 7th, we're doing wine and dine in the day.
Hey,
We'll be
there you go.
ready by then.
Yeah, I hope so.
Yeah,
Yeah,
that would be really.
That would
a neat
be.
thing to shoot for.
yeah. Maybe I'll invite Jonathan. He does a really good talk on this. And he is, my slides are animated, but he has next level animation because he's much younger.
It's hard to believe.
He has next level animation, and my daughters have they're going to be designing my slides from here on out, because what they do is incredible.
Yeah, that would be a neat thing to talk about during, at the discussion.
Yeah, I'll definitely invite.
Yeah, and if Jonathan wants to come, that'd be great. I'll just make sure we have.
On a panel, maybe, or no?
He's pretty nichey. I
Okay.
mean, he is that cell in myeloma cell. And
Okay.
so, yeah, and he's a PhD. But yeah, but no, he could definitely, speak to our research for sure.
That would be neat.
No, let's talk about that.
Yeah, very good.
Great.
Cool. So, I think that anybody here and anyone, on the Zoom, if you've got questions, you can unmute and just ask them, or, you can put them in the chat box and I'll ask them. So we can keep this conversation going. And Hal, I heard that, you're a TV star now. Oops.
Is he on mute?
Yeah.
He's on mute.
Yeah. Well, unmute. Yeah,
What was the question?
I said, I heard that you're a TV star now.
Oh, yeah, Channel 7. Yeah, big. All my friends are giving me feedback about my performance.
You, that was probably quite a nice day. Looks like it.
The segment is available on the WXYZ website if anybody missed it.
Right, well, and actually, probably later today, what we're talking about, everyone, is the MMRF walk run that was held on Saturday morning. And Channel 7 came out and did 4 different segments, then plus one for Hal that was shown later on in the day, in the evening. I'm going to be I have the links to those segments and I'll post them on our website or put them in on our Facebook page so everyone can take a look at those too. So you'll get even more publicity, Hal.
Just don't go on strike with the Screen Actors
Yeah.
Guild or the writers.
You got the grad students at U of M now, they're out, I think.
Are they?
I think so.
Oh,
Oh,
wow.
wow.
Yeah, I think the grad students went out and, from what I've heard, listened on the radio, they haven't gone back to work.
Mm.
I think more pay is what they're looking for.
Hmm.
They have a history there. I believe they're
I'm a
union.
reality script, so I'm a reality star.
Yeah,
You are.
yeah, for real, that's for sure. All right, well, anyone has some, here, I've got to add someone in, but anyone have questions out there, just unmute and ask them. We've got, our expert right here, Dr. Cole is happy to answer questions. And anybody here in the room can ask
I have a
questions.
question. Is there any of the major drug companies coming out with anything to deal with myeloma that's above and beyond what's out there now?
Oh, my goodness. That's such a good question. Because there are sort of two different ways to answer that. Is that, is there anything that is novel in the current armamentarium of looking at myeloma? And I would say that one of my favorites is, I think, BMS or the old Celgene is Mezi, which is the next level IMiD, or the next level Revlimid, called CellMod, or a cell modulator drug. So one thing that kind of blows my mind is that, for induction therapy for myeloma, we still use Revlimid. And Revlimid dates back to when I had hair, and was much thinner, and my knees didn't hurt. And the fact that we've been using that drug the same drug for induction therapy for 20 plus years
Really? Wow.
is kind of incredible. And one thing, and then and of course that was right from thalidomide. Pomalidomide came out, and then there was a fairly good gap Iberdomide was still in clinical trials, but Mezi is a completely next level drug. And in early phase clinical trials, the response rate for that drug really, knocks at the door of some even the cellular therapies that we're talking about, and that's a pill. And when in my mind's eye, think about using that drug as upfront therapy for myeloma. Right now, it's in, getting into late phase clinical trials for relapse refractory myeloma. But, you dial that and put that in as upfront therapy. I mean, that's going to be, I think is going to be incredible. So I think that, and the ease of that, because, one thing about a lot of the new drugs in myeloma is access. And, one thing that we look here at Michigan State, and I think really the myeloma community is looking at, is that we have these fantastic new therapies, but does everyone have access to it? And, CAR T, fantastic therapy, but does everyone have access to it?
Can afford it.
Or can afford it? The bispecifics, we do the bispecifics here, but does everyone have access to it? Because the people who I worry about, I worry about the people in my backyard, but then I have more of a global worry, the patients in the thumb of Michigan and the patients in the UP that don't have access to some of these fantastic new therapies. Is how can, the challenge I think that we have in myeloma is to have very, very, very effective therapies that also have access to everyone. Because my philosophy is that, is have we put patients in long-term remissions with myeloma? Absolutely. Have we, quote, even though we don't have a definition of cure yet, have we cured patients with myeloma? I think we've cured some patients with myeloma. But you can't say that you've cured myeloma until you have cured everyone with myeloma, including the people that don't have access, including the people in the UP, including the people in the thumb, including the people in Detroit. And so, the challenge is to try and make a therapy that is very effective, low toxicity, but also is accessible both financially and logistically to everyone. And I think, along with the cellular therapies, which are taking off, the bispecific, the trispecifics, and the CAR T therapy and the CAR T cell therapies, I do sincerely believe that looking at more biologic therapies and looking at the cell modifiers and looking at some of the oral therapies that are more accessible is also an important thing. And that my worry is that sometimes when you look at a lot of the myeloma research, it's dominated by the cellular therapies, which I think these are fantastic things. I've seen incredible things come of that. I mean, people whose lives were totally saved using cellular therapies. But I worry because I can give those therapies here to my patients, but I can't treat everyone with those treatments. And so, the therapies that I'm most excited about are, the one part I'm very excited about are the therapies that I can give right here that do incredible things. Like the CAR T and the bispecifics and that sort of line. But I'm really excited about therapies that will be able to give to massive numbers of patients with myeloma, that regardless of where they live and what their access is, they will be able to do it.
I have another question, if you don't mind.
Sure.
Now, when you talk about a cure, but you don't say it's a cure because everybody's been cured, does that suggest that that whatever the patient's been getting, that myeloma won't return after a period of time?
So
the medical scientists can.
Yeah, that's That's a really good question. It is really good because we don't have we don't have a consensus answer for that. And so there have been whispers that because there an official definition of what cured myeloma looks like now. And so there are a lot of people that walk say that, well, if you're off maintenance therapy and the disease has been away 5, 10 years, then you're cured. Um, but there isn't a definition. And until we have a definition of what that looks like, because you could say, if you're on maintenance therapy for 10 years and you die of a shark bite, that you're cured of you're cured of myeloma. Other people would say that you need to be off of everything and die of natural causes. And I'll tell you that myeloma is multiple myelomas, and so that the problem that we have with I would say, if you ask me what's the biggest problem that we have in myeloma, is that not only do we not have a definition of what cured looks like, but we really don't have a definition of what myeloma looks like. And when I say that, is that if I go to one of our hemonc fellows and I say, how do you treat diffuse large B-cell lymphoma? So, a lymphoma. The fellow is going to come back and say, well, what type of diffuse large B-cell lymphoma are you talking about? Is it activated B cell, the germinal cell B cell? Is it double hit? Is it triple hit? Is it double expressor? Because those diseases, the leg type diffuse large B cell lymphoma, because they're all treated differently. If I go to the same fellow and I say, how do you treat multiple myeloma? That fellow here, because I train them, they're going to say Dara RVD. They're not going to ask me what type, because we don't have those types figured out. And the reason I think that that's important is I'll tell you a story. That's okay. That it was a real wake up call to me, is that I did a talk in Colorado years ago. And I did the talk, this was, before COVID, and did my talked about newly diagnosed myeloma. I got off the stage and this lady comes up to me and she says, I really liked your talk. I said, thank you. And she said, I had myeloma. I was diagnosed with myeloma in 1970 something. She said, I got 4 days of dexamethasone. And then I got another 4 days of dexamethasone. Never had any other treatment after that. And I was like, and I didn't do that. But I think the look on my face was, you didn't have mine. And so she picked up on that. And she was like, very nice. And I was like, oh, that's great, that you haven't had any therapy in like 25 years with this disease. I come back the next year. She's in the audience again. I do my talk. I get off the stage. She comes up to me, but she has an envelope. And she said, do you remember me? I was like, of course I remember you. She said, and she takes out the envelope and had her bone marrow biopsy. She had myeloma. I was like, how does this person have myeloma 20 years ago, only get dexamethasone, never relapse, never anything? 60%, I'll never forget this, 60% plasma cells in her bone marrow in 1970, I forgot the number. And that speaks to how we don't quite know the different multiple myelomas. And I can tell you about some of them. I can tell you about the 17p deleted myeloma. I can tell you about the p53 mutated myeloma. I can tell you about the bad actors real easy. I can tell you how to treat the bad actors because that's a squeaky wheel. But when you get into the more indolent types of myeloma, we know very little about that because, and if for good reason, a lot of our concentration has been in the people who relapse repeatedly. All the research has been in the people who continuously relapse, because that's our greatest need. But my worry is that we overtreat some people, and that we have cured some people, totally cured some people with myeloma, but we still have them on maintenance therapy. We still are treating them as if they were the worst actors. And there's a lot of research trying to figure out those different types. The MMRF has been working on that for years with the COMPASS trial. But I would say one of our biggest priorities is to define cure, because there are people that we have cured with this disease. We just don't know it. And we need to define the different types of myeloma better. And, Jonathan Keats is a laboratory and clinical researcher that that's in Arizona, that's worked on the molecular definition of myeloma. He worked with the MMRF, worked on the COMPASS trial. And he and I, what meeting was that? We were at a meeting together, I forgot which one. I think it was the NIH meeting. And he said the toughest disease that he has ever worked on to define the different types is myeloma, hands down. Because myeloma, unlike the B-cell lymphomas and some of the solid tumors, the cells die so quickly when they're taken out of the bone marrow. And so it's hard to do research in live myeloma cells because they die so quickly outside of their environment. And I would say that, the research that I'm most excited about in toto is trying to figure out those different types. Because obviously there are patients with myeloma that we only need to give them very finite, very small amounts of therapy. And there are patients we need to give them the entire kitchen sink and armamentarium. But who's who in that, we don't know yet. Does that answer your
Oh, yeah,
question?
yeah. Thank you.
Anybody else have questions for Dr. Cole?
I have a question. This is Steve.
Hi.
Hi.
Okay, I had a stem cell transplant last July 1st. And it's pretty evident that the transplant has failed. Let's see, my M spike has been going up. My kappa free light chains are up. But what I haven't been able to figure out is how many are there statistics on how many transplants actually fail or are not successful? Because I have never been able to find that.
Yeah. So those numbers are kind of hard to come by, in part because it's hard to define what a failure is in a stem cell transplant. I would say that, what's happened, and how many years has it been since your stem cell?
He's on mute.
Unmute.
Sorry, how many years for what, doctor?
How long has it been since your stem cell transplant?
Oh, I just had the transplant last summer, July 1st.
So less than a year.
About 7 months.
Yeah. And so, and when I say that's kind of hard to define what's a failure for stem cell transplant is what's the expectation of how long does a transplant last? I think that a loose definition is that if you have a recurrence 2 years after your stem cell transplant, that's considered a failure. Some people think that's 3, some people think that's 1 year. And so because, the measuring stick moves, it's kind of hard to come up with those numbers. But on average, a loose number would be about 10-15%, maybe 20%, depending on the population and what you define as the definition of how long a stem cell transplant would last. And, and the things that add to, so what are the things that add to a stem cell transplant failure? Right now, what we kind of focus on is cytogenetics, that people who are 17, again, 17p deleted, 414, 14, 16, 14, 20, and amplifications of chromosome 1. So more than 3 copies of chromosome 1 are the people who are more likely to have transplant failures than other groups. The one thing, I was just on a meeting late last month, talking about how we don't have a uniform, gosh, I sound like such a downer. We don't have a uniform way of checking those cytogenetics, because not every place does plasma cell sorting in order to only test the myeloma cells and so I think that there's some high-risk patients that are coming that are kind of falling through the cracks, that are truly high risk, that we don't know that they're high risk. But basically, the higher the cytogenetic risks that you have going into it, the higher the risk the transplant will fail. Does that answer your question? I hope.
Yeah, I think so, pretty as well as can be expected, because I kept on asking my doctor. I said, well, has it failed? And I really never got a definite answer, because you can't. How do you define fail?
But I would say that in less than a year, and the protein is beginning to go up. Now, one thing that can sometimes happen is that every blue moon, you'll have a patient that will get a transplant, and soon after the protein level will go up, and then I'll come back down. And somewhere in like 3 to 5 months, the protein level will come up and then it'll come back down. And then it will continue to go down. And those are the folks that you have to be a little bit careful in saying that they've failed. Because, the one thing about the stem cell transplant is that the chemotherapy, especially particularly in the myeloma cells, can take a bit to kick in. And so sometimes you'll see a surge that will happen, then it will fade away. And so, if a patient has an M protein that rises in their first 3 months, I tell them, don't panic quite yet. Let's see how things go. And then it should come back down. If it goes up and up and up and up, then that's more of a failure.
Yeah, we've been watching it for about 3 or 4 months, and it has been steadily rising.
Mm-hmm.
So I started a new therapy Friday, which is Dara, Pomalyst, and Dex. Yep. So it just happened. So, and I think to me, that's pretty much standard therapy at this point. So, okay, thank you.
Yeah, thank you.
Anybody else? Others here can ask questions too. Anyone in the room want to bring up a different subject here about multiple myeloma? Often we get questions.
I'm on Zoom and I would like to ask a question.
Yes, my name is Danuta, and I have a question about, as a member of multiple myeloma community, as a patient myself, have a question about Revlimid, the wonder drug. It does do good for me. And I wonder why generic form is not used here in the United States, because I know it's widely used in Europe and other country of Asia. Any word on equality? And because so many people have problem with accessibility to the prescription of regular Revlimid, why can we use here to help people? Any word on this subject?
Yeah, that's a super, super good question. So the generic Revlimid is being used more and more. And so it, I guess the one thing is that that was just, relatively recently approved. And I think it was sometime last year, either early last year or the year before that, they were approved. And in a lot of, it takes quite a bit of time to have a lot of the generics filter down, especially when you have a drug that's 20 years old. You get very used to writing the same drug, in the same way that, I've been wearing the same style of shoe, I think, for 20 years. My wife keeps telling me I need to change things up, and I'm like, no, I kind of like the shoes I wear. And so, but it's not the same pair, of course. But it takes a while for practice changes to take place. But a lot of especially the pharmacy groups that are, the prescription coverage groups will change, the Revlimid for one of the generic lenalidomide types. And actually I have to, double check. Not that I have a preference for the generic or the prescription or the brand name type. But I just like to know, which medication my patient is receiving. So I think it's part of the delay in getting it through our practice patterns that people are kind of used to. Even the pharmacies are kind of used to when you've been having the same drug going for the past 20 years. It's just a bit slow in getting it changed over. I think the big question is, there are, from what I understand, that the pricing is a little bit more subtle than I thought it would be, that it's not a dramatic difference in price, but a bit more subtle difference in pricing. And hopefully that will change in the next few years. The one thing I was really excited about that I still haven't seen that's come out is that there was a Revlimid generic patch that was going to be available. And I haven't, I'll be honest, I haven't looked it up in a while. But, I thought that would be, a fantastic option, especially for patients that are in maintenance therapy, to wear a Revlimid patch. Was a generic Revlimid. And so we'll have to see, where that is. And I think that was still in the trial phase. And it hadn't come out yet, but that would be exciting to see. So I guess, the short answer is, I think we're getting there. I know that I would say maybe a third of the patients that I have are getting generic, and 2/3 are probably still getting name brand. Do I have a personal preference? I usually don't have a personal preference.
Thank you, doctor.
MA on this, visiting has a question. Go ahead, with your question.
Okay, here's my question. And it's about multiple myeloma using THC or CBD products for sleep or for appetite or for fatigue. And what are the thoughts about that?
Yeah, so there hasn't been, so do I prescribe any of that? I don't. And so kind of the university doesn't allow us to do that. The one thing I don't know is I don't know how those drugs interact with the current myeloma drugs. There was some research that was done a few years ago with CBD and THC projects in carfilzomib that were very small trial, small studies that thought that maybe there was some advantage in symptoms with using those products. But the one thing I worry about is interaction that we may not be aware of. And for instance, one thing that is kind of nuanced, but I think a lot of my patients know, is that a few years ago, actually about a decade ago, is noticing that flavonoids, the green part of like green beans and peas.
Sorry about that.
Okay, I was the one that asked the question, and I have to say that the screen just froze, so we don't know what you said
Yeah.
after I asked my question.
Yep. So I think that we don't know. And there's haven't been in my concern of why that we don't use it ubiquitously in myeloma, our interactions with some of the medications. And one of the examples of that is the flavonoids, like the green part of green beans and peas and broccoli, has a subtle, but an interaction with the boronated proteasome inhibitors, specifically Velcade and Ninlaro. Those drugs, when taken at the same time, so if you eat broccoli and get your Velcade on the same day, in the laboratory, the flavonoids can inhibit the function of bortezomib. And what I kind of worry about is using those products while you're getting therapy, like again, the Revlimid or the Velcade, even though those haven't been quite proven. Can those drugs be helpful in symptom relief? I think that's a really good question. Do I have some patients that actually do that? Yes. But do I make sure that there is some time away from their active therapy, and when they use those products, I try to space them out as far as I can in order to make sure that there's no potential interaction between the two.
What kind of spacing are you talking?
Hours, so that they take them at bedtime. If they get the therapy in the morning, then they take those things at night. I do have patients that do that and have benefit from that are able to sleep better and et cetera. One thing I'm thankful for is that a lot of the myeloma medications don't have a lot of nausea associated with it, so we don't have to worry about nausea so much. And for appetite, there are a lot of different things that help with appetite that aren't as sedating, because the one thing about myeloma is that I always tell people that myeloma is a cancer of adults. What I mean by adults is the vast majority of patients that have myeloma are over age 50, and the median age is about 65. And some of those, the THC and the CBD products can have problems in people who are older, people in their 70s and 80s and 90s. And so they have to be kind of careful with that.
So you said, I was just curious about the flavonoids.
Mhm.
Do you tell people not to eat broccoli when they're going to have treatment?
Just on that day, on that day and that day only.
That's interesting to know.
Yeah. And so so no one has done, so this was a finding that was done in the laboratory that was published about 10 years ago. no one, will do a clinical trial on that. No one's gonna give someone broccoli and let's see if your Velcade doesn't work. Because that would be a bit unethical to do that. And so it's a laboratory finding, but and the one thing that that laboratory finding did show is that it's very short-lived. And so it's just that one day. So if you can, I tell everybody, you can eat broccoli every day, every single day, except for that one day a week that you take the Velcade, is that the day you don't eat it.
So then when we see our doctor for treatment, should we be asking if there's certain foods that we need to avoid with whatever our specific medications are?
Yes. Yes, absolutely. And there's really not a lot of food drug interactions in myeloma, thank goodness. But the one that that we know about probably the best is that, and that's the borinated proteasome inhibitors. And so, carfilzomib, which is an epoxy ketone, there's no known interaction between those drugs, but the borinated ones, Velcade and Nilara, are the ones that have that interaction that we know of.
But also, I think I hear you saying, I don't want to misquote you, but nobody's really looking at, like, if you wanted to take a gummy for sleep, how, and you have multiple myeloma, obviously. And again, since gummies come in so many, different varieties in terms of what they might contain in them, THC or CBD, nobody is really looking at this. And I imagine it would be pretty hard to try to even study that. But as far as is anyone looking at CBD or THC products, to help in treatment?
That
Oh.
and some small studies I've seen with carfilzomib, I haven't seen any large studies that would be practice changing.
Okay, thank you.
Or that I would, have a particular recommendation for. Again, there was one study that was done in Europe a few years ago with THC and carfilzomib, but that was the only one that I've seen, and I haven't heard of, and it didn't move on to any larger research trials that I've seen.
Well, I guess I have one more follow-up question. And, I always know that MM patients should not be drinking alcohol, or you should be drinking it in very limited quantities. And so I guess I'm just, thinking that I don't know if that could be the same, like if you wanted to take a gummy to sleep one night, but you're not taking gummies every night to help you sleep. So I'm wondering if you just take something like that on occasion, if it would really affect your treatment.
Yeah, I guess I don't think so. But I think, and again, there, other non psychiatric methods to help with sleep, like melatonin and things that can, definitely, one problem with sleep is definitely dexamethasone. That dex and sleep don't mix. And are there, a variety of methods to help with sleep, especially associated with dexamethasone, besides THC, definitely. And so I would, I think a recent, actually kind of, I would say, trend that has really worked well for a lot of my patients is using trazodone. That in very low doses, trazodone does a great job in having people go to sleep without having them feel all wonky and sort of hungover in the morning. And so that's, I would say that a lot of the patients that I have that are on Dex, when they complain of sleep, that's, melatonin as a start, and then moving to trazodone if that doesn't work.
One thing that I found that has helped me not overcome the dexamethasone, but there is a course available through Gilda's Club on mindfulness. And if you can focus, like when I'm trying to go to sleep, I wear a CPAP mask, and sometimes if I don't get control of my mind, I can get kind of panicky with that mask on, especially if I'm congested. But if I focus on my breathing, or if I focus on relaxing my body, one little piece at a time, which I learned through the mindfulness training through Gilda's Club, that helps me. Next thing I know, it's morning, so it does work for me.
And I've actually, I forgot, I had an app that was meditation that I used to use until I did it so many times that I didn't have to use the app. And to this day, I still, meditate to go to sleep. It works well.
Probably Calm or one of those apps.
I think it was, I think it was Calm. That was it.
Yeah, they got a lot of nice different apps. The other thing I found out with dexamethasone is when I'm coming up for treatment where I have to take that, I plan a lot of activities to kind of take advantage of it to keep me busy, to kind of, because I stay up for a long time, but I can get a lot of work done for the 2 days after I've taken it, because it's just keeps you moving so quick. And then you get to a point where you kind of get it out of your system. It seems to help.
That and dividing like over 2 different days. And so, you take, 20 on treatment day and 20 the day after treatment, can work too. And some people, especially if it's activating late, so you take dexamethasone in the morning and then you feel, hyper, and, at 4 o'clock or 3 o'clock is taking it, the dexamethasone at night. And so there are a few that take the Dex at night so that they actually take it at night, they sleep, they wake up, with energy, and it kind of fixes that kind of sleep thing. And as you take it at night, you take it in the morning and it's activating at 4 o'clock, then you're up all night with it. And so, so it sounds counterintuitive, but it works for some people.
It did work for me to take it at bedtime. And you're not supposed to take Dex on an empty stomach, so I would, eat a graham cracker and take my dexamethasone at bedtime, and it would take about 6 hours before it would kick in. So I'd get 6 hours of sleep before the Dex would kick in. But the other thing is I take temazepam when I need to overcome the effects of dexamethasone. And, I've experimented with everything from 15 milligrams to 30 milligrams. And the right dosage for me is 22.5 milligrams, because I've tried them. And that gives me 7 hours of sleep with no grogginess when I get up in the morning. So, that works for me. But, everybody else may be different. We're all different.
Yeah. And I would say that probably one of the research, again, kind of circling back to where we started, the research that I'm most excited about is how many studies are taking place without dexamethasone, and how we're trying to get it away from using Dex, because we've been using Dex, since we're using steroids since the 50s, and and it was in the 80s and 70s that, high dose Dex, and we've basically been running that for such a long time. And I think one of the most important studies that came out of the, the practice changing for me that came out of the ASH meeting, and there was a International Myeloma Working Group meeting that also took place this past December, was a study called the IFM 2017 study, where they got patients with newly diagnosed myeloma, and they gave them, I should back up. There was a study that was done called the Maya study, famous study, Maya, international study, daratumumab, Revlimid, Dex. And that was Dara, Rev, Dex versus Rev, Dex alone. And it showed that Dara, Rev, Dex was superior to Revlimid and Dex alone. So then there was the IFM 2017 study that was really interesting because it had randomized patients between Dara and Rev, no Dex, except they had Dex in the first month or so in order to prevent or infusion reactions and injection reactions. So after the first couple cycles, they dropped the Dex. And that was compared to Revlimid and Dex. So Dara, Rev versus Rev, Dex. And actually the outcomes were better with Dara and Rev without the Dex. And of course, there were less side effects and less infections because people weren't on the dexamethasone. And then you would ask, well, how does the Maya study, the Dara Rev Dex, compare to the Dara Rev study? And I would say you're not supposed to do cross-trial comparison. So you shouldn't compare the two. But I'll tell you, I did it anyway. So I pulled the Maya study and compared it to the IFM 2017 study. And actually, even though, again, this cross-trial comparison, very different populations, very different numbers of patients, they're pretty comparable. And so what I've been doing based on the IFM 2017 study is patients that I'm treating with Dara Rev Dex as induction therapy. None of those folks are on dexamethasone anymore. I've stopped and weaned them off Dex. And in patients who are on long-term Dara, IMID, POM or Rev, I've weaned them all off the dexamethasone. And based on that study and based on that, it really, I'm not quite sure what we're buying when we have patients on long-term dexamethasone other than toxicity.
Interesting.
I had another question. I was hoping to ask you if I understood you right earlier, you were talking about therapies that are taking off now, and mentioned CAR T, and I think you said bispecific and tri-specific.
Yes.
Is that instead of putting patients on one like oral chemo, now putting them on a combination or 2 or 3 meds, you're finding that works better? Because I'm just asking if that's what it is. I'm not sure what you were talking about.
That's, I mean, they're all good questions, but that there are, I mean, the question is we've been doing these 3-drug and 4-drug therapies for myeloma, as long as I've been doing this, which is ends up being kind of a long time. And can you replace the 4-drug induction therapy for myeloma with a single CAR T-cell therapy or bispecific therapy? And those trials are ongoing, and hopefully we'll have a readout this December to see how those trials are doing. Because the idea is that the CAR T cell therapy, which basically genetically engineers the T cells to kill the myeloma cells, and the bispecific antibodies, which pull the T cells in close proximity to the myeloma cells so that the T cells will kill the myeloma cell. The great thing about those therapies is how unique they are. The bad thing is that is that patients have been on lots of myeloma therapies leading up to using those therapies, and that those T cells are tired because Revlimid activates T cells, Pomalyst activates T cells, the chemotherapy for transplant, kills off some of the T cells. And so by the time that you've had 5 different rounds of therapy, when you're eligible for CAR T bispecific, your T cells are tired because they've been fighting for 5 years, or 5 different lines of therapy, and maybe fighting for 15 years. And the idea is that using these therapies up front and fresh T cells that have not been, fighting cancer and been exposed to all these different medications may have, better outcomes. And so we'll have to see. And so those studies hopefully will read out this coming December.
So,
What is your experience with Revlimid, Dara, where there's the patients having difficulty with Revlimid, such as infections and other reactions going to just Dara? What's your experience with that?
Yeah, that's a good question. And so it's been interesting because it seems like there's a long period of time, where the side effects from Rev were pretty minimal. And more recently, I've had more patients that have had reactions to Rev, like fever, has been we actually talked about it at our meeting a few weeks ago about fever associated with Revlimid, more rashes associated with Revlimid. And so one thing that has been recommended for a while, especially when patients that have myeloma have immunoparesis, which means that they're normal, the myeloma is producing all these antibodies, the M protein, but also it can suppress the production of the natural immunity that patients have. And immuno means, the immune system, poiesis means reduced or impaired. And when patients have immunoparesis, the recommendation have been in the first month to 2 months to have those people on antibiotics. And definitely if a patient is newly diagnosed and they have any infection prior to being diagnosed, that I'll have them on antibiotics for the first 2 months, because they have declared themselves as a person that is likely to get an infection. You're 100% correct in that adding the daratumumab as part of our induction, we've known that daratumumab increases the likelihood of respiratory infections like pneumonias, sinus infections. And so definitely when I have patients on the 4 drug induction therapies, or when I have them on daratumumab, that either I'm very conscious of and have a very low threshold to put them in antibiotics, or sometimes I put them on prophylactic antibiotics just to be safe in the first few months. What I mean by the first few months is that the great thing about some of these therapies is that they kick in pretty quickly and the immune system begins to as the myeloma goes down, the natural immunity begins to go up. The immune system reconstitutes itself, and then I don't have to use antibiotics as much. Great question.
What about related to maintenance? That's what I was talking about with the Revlimid, Dara. I was using both, but Revlimid was a problem where you talked about a little bit about infections. It actually went into like an RSV pneumonia type of thing.
Yeah.
And then we just discontinued the Revlimid with my current doctor. And it seems like the Dara itself is doing okay for now, but it's only been several months.
Actually, Rev in maintenance therapy doesn't have a high risk of infections. And when you look at the side effect profile between the two, the Dara has a bit higher of a side effect profile when it comes to Rev. And so honestly haven't seen a lot of infections related to maintenance Revlimid. We have a bunch of people on maintenance Revlimid. Things like RSV though, and some of those, endemic, infections definitely are worries. And so, COVID, as we found out, that patients don't do well with the COVID vaccinations when they're on Revlin maintenance and need those boosters to go along with. And, and hopefully we'll have, a better solution for RSV. I have seen the RSV go through myeloma populations of patients, and myeloma patients seem to be particularly sensitive to RSV infections. The good thing about those infections is that usually they're pretty seasonal, usually they're fairly endemic, and then they kind of fade away. But does Rev and or DARA predispose you to infections like RSV? Absolutely. You have to be especially careful with those infections when people around you and people in the area have it. You have to be pretty careful with it. Once it goes away, can you then consider the Revlimid again? You could consider the Revlimid again.
Thank you, Dr. Colt.
Thank you.
Well, we're past an hour now, and so if there's, I think we'll kind of start to wrap it up. If anybody has another question, we could probably do a couple more, but we can't keep Dr. Cole here forever, so.
Not for forever. My family will wonder what happened.
Right.
They know where I am.
So, Jim, you had a question earlier. Did you get your question answered?
I think I did, yeah.
Anyone else have a last burning question before we kind of wrap this up? No, you're all okay?
Thank you. It's been very informative.
Yes, it has.
Oh, great. No,
Yeah,
I think, the, it's really, I can't underemphasize how exciting things are in myeloma, in the myeloma community right now. It's really the changes are really quite dramatic. And every time I look up, the interesting thing is that there used to be only, the American Society of Hematology meeting used to be the only meeting where myeloma doctors used to get together. And now there's, Whistler and Comey and IMS, and, there are several meetings where myeloma doctors get together to talk just about myeloma research. And and it's because one forum can't hold all the research. And it's because there are so many people involved in it now. And a few years ago during one of these, I think someone asked me what's the most exciting thing that I've seen in myeloma research. And I told them that there was an ASH meeting, the American Society of Hematology meeting that Jeff Zonder and I went to. And we had, I think we had a beer somewhere, and then we went to the meeting. And we got to the meeting like 15 minutes ahead of time, and all the seats were taken. And then we went to, this big, huge auditorium. Then we went to another one, all the seats were taken. And then there was an annex in the middle of the hallway where they put, a projector and put seats down. And we got there and I was like, holy smokes. And I looked at all the people that were already there. Everybody had hair. Everybody was wearing sneakers and t-shirts. And I'm like, all these young people are invested in this cancer. All of these young minds. So it's just not a bunch of, bald-headed, gray-haired people, but all these people young people who are invested in this. And if you ask me, how do you cure myeloma? You cure myeloma by having young, motivated people with fresh minds coming up with these incredible ideas. And still, I mean, now I know to show up a half hour early to all the meetings, so I can get a seat like midway. But it really is, it's incredibly exciting times, and things are changing so quickly. It's good to have meetings like this, and thank you for coming to East Lansing today, so that, you know, I can hopefully give you a little glimpse of all the great things that are happening.
So Mildred, put something in the chat right here. It says, I'm from Puerto Rico. I have question about reaction about dextromethasone and that give me face rash and ears. I take Benadryl, but not function, have pain and redness is very difficult. I have 49. I have 49. That's-
I knew it was 49.
Yeah, maybe she's 49 years old.
Yeah, you know, and dexamethasone can, you know, we just had someone that had some facial flushing and a rash associated with it. And we had to reduce down the dose of the dexamethasone. And I think one thing that we've learned over the years, you know, what we used to do with dexamethasone is that the dose used to be, and I think I'm the only person that remembers this, it used to be 40 milligrams, days 1 through 4, 9 through 12, 17 through 20. So it used to be 4 days on, 4 days off of Dex. And that's what has been the running dose for decades. And I remember that because I used to write that prescription when I first started doing this over and over and over and over and over again, 120 pills. We've then found out that giving 40 milligrams of Dex once a week was effective. And then we're finding out that 20 milligrams dexamethasone is still very effective. And so, you know, so I think we're still, you know, struggling a bit to see what the right dose of Dex is. Because we have all these exciting therapies, and how much Dex you actually need to actually have, you know, these therapies work as well. And so I think that one thing that I have a very low threshold in doing is reducing when people have side effects. And so, you know, I think that if you walk through my clinic and talk to my myeloma patients, you'll see that there are people that are perfectly fine with 40 milligrams of dexamethasone. We have people on 8 milligrams of dexamethasone. We have people on 20 milligrams of dexamethasone. We have people like Hal that are on 22.7 milligrams of dexamethasone. And so I think it's important to find that best tolerated dose. And so if you're having problems with it, I would ask, you know, talk to your doctor and say, you know, can we change that dexamethasone dose to find the right fit for you?
She says, it's hard for me to read. I use Darzalex and Propolis one every Tuesday. I don't know, is some of this medication do the same?
Darzalex, not so much. Kyprolis, Darzalex can cause local skin reactions from where the injection is given. Kyprolis can also cause a rash. And so it could be that you know, the way to figure that out is really, you know, is eliminating the dexamethasone's potential costs. And so filling around with the dex dose may help you out.
Hey, well, I think that we need to end this so that we can get you back to work.
Yeah, I gotta get back to work.
Yeah, you know. So thank you so much for taking the time to do this. We really, really appreciate
Oh, yeah.
all this information. It's very, very useful to a lot of people.
Yeah, no, thanks. Thanks for coming.
Thank you.
Yeah,
you.
Yeah, yeah. All right, everyone, I'm gonna.
Thank you.
Thank you.
take care.
Take care, everybody. And